Hey guys, so I'm Ashwini and this is Anaya here, and so we're running the JEP call. We've got Jonathan and Dave. So we'll be going through life support, we're going through respiratory and cardiovascular, and we've also put some SPAs for the foundation module right at the end as well, which we'll just run through. So we've only got about 8 as well. The second is very SPA heavy.
Audio is kind of bad.
One sec. I think.
Yeah.
Good. Okay, great. So welcome to the life support crash course. We're going to kick things off with asthma. I'm Jono, like they said. So how's this going to work? Is you're going to get an SPA and then followed by a bit of sort of a slide with some information relating to that. So Dave, would you mind like looking at the chat for me? See?
Yeah.
Great. Get the chat up. So I'm going to put this SPA up. I'm going to start with just a quick little bit of anatomy histology. Just one question. Just type in A, B, C, or D in the chat, and David can tell me what's going on there. He can be like my Richard Osmond.
I'll take that.
Have we got any activity?
There's activity. It's happening.
Excellent.
It's kicking off.
I'll give you a little bit of time. All right. Give you 10 more seconds. All right, have we got some answers?
Mm-hmm.
Excellent. What are people saying? Thank you. Perfect. Lots of B's. Very well done. It's the right main bronchus. So I'm not going to go into loads of anatomy histology because it's going to be a very long night otherwise. So I've just got 3 facts here. First of all, foreign bodies are going to lodge in the right main bronchus rather than the left because it's a more inviting environment for foreign bodies. It's wider, it's more vertical. That's where they're going to lodge. Just a histology fact. It's worth knowing a couple of different kinds of a tissue that occur in the respiratory system. Like in the trachea and bronchi, you've got ciliated pseudostratified columnar epithelium. And relevant to asthma, which is your first topic today. So in the trachea and bronchi, you've got thick cartilage that holds those airways open. Whereas when you go further down the respiratory system into the bronchioles, which are smaller, there isn't cartilage to hold that open. All that holds that open is smooth muscle. So that's where the problem is in asthma, where you've got smooth muscle constriction. The trachea and bronchi are all right because the cartilage holds that open, but the bronchioles are where the real problem is because the smooth muscle constricts, the lumen becomes a lot smaller, and that's why you get that wheezing noise because it's air trying to go through a very small space, very small diameter. Okay, let's move on to something a bit different. Answers in the chat. Let's give you 30 seconds for this.
Some B's, some A's.
There we go. That's 30 seconds. So it's most likely to be a beta blocker. So the B's have it. Essentially, you can remember this because we'll go on to a bit of stuff on medications for asthma later. But the medication, one of the main medications we give for asthma is salbutamol, which is a beta agonist, which helps to open the airways. So you can remember it like, well, a beta blocker is doing the opposite of what the asthma medication is doing. So it's going to make the situation worse. And you really need to watch out in your SPAs for a person with asthma who maybe has like issues with their blood pressure or a heart problem, and you're wondering what to prescribe them. Got to watch out giving them a beta blocker because it might trigger that asthma. So this is just a general slide on asthma. Key facts are it's reversible airways obstruction. So if you give them a bronchodilator, a medicine like a beta agonist like salbutamol or an antimuscarinic like ipratropium, that will help to widen the airways. It's not something it's not airway obstruction there all the time, like in something like COPD. And it's intermittent, it comes and goes. It comes in sort of waves and in attacks, that sort of thing. It's caused by inflammation. It's very common, and key symptoms are a wheeze caused by that very small airway diameter, the air trying to just force its way through there. And you also get breathlessness, cough, and it tends to be worse at night in the early hours of the morning, because of the way that your hormones cycle throughout the day. And there are a lot of things that can trigger it. You probably all know, allergens can trigger your asthma, dust, pollen, things like that. You also get exercise-induced asthma. I've actually got a mild sort of version of that. I get kind of triggered a bit by exercise sometimes. And then certain drugs also can trigger it. You've got to watch out for aspirin and NSAIDs. Not necessarily contraindicated in people with asthma, just got to watch out. Some people can get triggered by those. But beta blockers, you really do need to watch out for in asthma, because it just does the opposite of what the asthma medications are doing, potentially closing those airways. We'll go into a bit more about that in a bit. Next question. 30 seconds on the clock. All right, we're getting a lot of C's, exclusively C's in fact. You don't even need me here. Excellent. IgE, that's perfect. I'm not going to go into detail on the pathophysiology of asthma, but I've got a couple of slides here on that, stolen shamelessly from your lecture. But basically there are two stages. The sensitization, when you first get exposed to the allergen, your body primes itself. It just becomes a bit overexcited and primes itself to attack that allergen the next time that you get exposed to it. And how it does that is basically via your immune system. You get beta cells which produce these IgE antibodies that go on the surface of mast cells. And when those IgE antibodies are specifically designed so that when the allergen binds to them, the mast cells will absolutely lose their minds and just spurt all of these inflammatory mediators everywhere, causing like smooth muscle constriction, inflammation, edema, that kind of thing, causing that asthma attack response. And you also get chemical messengers like interleukins, which recruit other immune cells that do a similar thing to the mast cells. So this is then, you get exposed to the allergen again, mast cells absolutely lose their minds and just blast all these inflammatory mediators everywhere. You get your smooth muscles in your bronchioles contract, mucus secretes, edema, swelling, all of these things causing a narrow airway lumen. And then you also get your eosinophils causing an inflammation as well. That can happen a bit later. The mast cells are quite an immediate response. The eosinophils can come along later. That's why we need to watch out. We're admitting patients with asthma attacks. Don't let them go home too soon, because they can get a second wave because of these eosinophils who are a bit later to the party than the mast cells. Next question. 30 seconds on the clock. These questions are harder now. I might actually give you a tiny bit longer, but also doesn't matter if you get it wrong. Like, we're here to learn. Okay, so giving you a little bit longer there. We've got a variety of responses, some C's and D's mainly, but also a few B's. This was a much harder question. Well done to the people who said D. We're going to go into that a little bit now. Don't worry the other people, because this is harder stuff. So spirometry is basically you get them to blow into this great contraption that will help you to tell the difference between whether that person has an obstructive respiratory condition or a restrictive problem with their lungs. So spirometry measures your FEV1, that is the amount of air that you can expel in just 1 second. and it measures your forced vital capacity, which is the total amount of air that you can use in your lung volume. Like, so that is your kind of a measure of how much air you can get out of your lungs in total. So in obstructive conditions, the amount you can blow out in 1 second is low. It's low because it's like trying to blow out lots of air through a straw. The airways, the problem is with getting the air out of the lungs. It's not with the amount of air in the lungs. That's normal in someone with asthma. It's just that their tubes are very narrow, so you can't get it out. So the amount you can get out in 1 second is low, but the total amount of air, if you let them blow for ages, the total amount of air that they can get out is normal, or maybe a little bit decreased, but basically pretty normal. Whereas in a restrictive condition, the FEV1 and the FVC are decreased. They just have less air overall in their lungs that they can get out. Their lung volume is reduced that they can use. And restricted conditions include things like lung fibrosis, where you've got lots of kind of scarry tissue that is just kind of obliterating bits of the lung. So you just got less lung volume because more of it is kind of scarry, fibrous tissue. And it's also things like obesity, where they can't expand their lungs fully because you've got fat in the way that's stopping them using their full lung volume. And neurological diseases as well, where the problem is in the nerves, and that's what means that they can't use they can't breathe fully. So basically, because in obstructive conditions, the amount you can get out in 1 second is low compared to the total amount in your lungs, you get a low FEV1 over FVC because of the magic of maths. That's how it works. It's below 0.7. Whereas restrictive conditions, everything is low. FEV1 is low, FVC is low. So FEV1 over FVC is going to be closer to 1. It's going to be above 0.7. So basically, the thing to remember is if your FEV1 over FVC is below 0.7, that's obstructive. If it's above 0.7, that's restrictive. But this is a hard kind of top tier question. So if you're getting this right, you're doing really well.
And I've got a question here. Is bronchiectasis obstructive or restrictive? Good question.
Good question.
You don't need to know a huge amount about this now. In fact, you don't need to know anything about this now. But for future reference, bronchiectasis is an obstructive pattern on the spirometry, and that's because even though you've got really widened airways in bronchiectasis, they're bunged up with loads of mucus. Like if you take one thing away from that question, bronchiectasis equals mucus. Like there's just mucus everywhere.
Yeah.
And again, it sort of creates these narrow airways.
You don't need to know that for this year. It kind of comes along with cystic fibrosis and other sort of things that you'll learn later on. So next question. This is again very hard. I do apologize. The questions get a bit better after this. I believe in you. All right, you've actually mainly done extremely well on this question. Most people putting C. Got a few other things there, but mainly C's, which is excellent. It's pulmonary fibrosis. So you all remembered that 0.9 on spirometry equals restrictive, so it's not going to be asthma. That's great. It's going to be something like obesity, pulmonary fibrosis, and something along those lines. Now, transfer factor is basically something that tells you how well gas exchange is happening in your lungs. How well is a little bit of oxygen in your alveoli getting onto your red blood cells? So if it's reduced, there can be multiple reasons for that. It can be because the membrane between the air and the blood is very thick in pulmonary fibrosis. So that's one thing. So well done. In this question, pulmonary fibrosis is the right answer because of this thickened membrane causing the reduced transfer factor. Obesity, you're not going to have a problem with your gas transfer in and of itself because there's nothing wrong in the lungs. It's just what's around the lungs that's stopping them expanding. And then another reason for reduced transfer factor, reduced gas transfer, is where you got your ventilation or your perfusion. So there's a difficulty in the air kind of getting into your alveoli, or there's some kind of difficulty in the hemoglobin, the blood rushing along and getting to those alveoli. So there can be a problem in, something like emphysema, you've got a lot of destruction of alveoli, so you've got less kind of lung, less sort of surface area, which is reducing that gas exchange. In something like pulmonary embolus, you've got a decrease in perfusion, so there's going to be less gas transfer because your hemoglobin, your red blood cells cannot get to that gas to be exchanged. And then transfer factor, don't worry too much about this, but transfer factor might be increased if you've got like something like a big hemorrhage, which is obviously a terrible thing. Because you've got loads of red blood cells being exposed to lots of the oxygen in the alveoli, but obviously not in a useful way, in a very detrimental way. Next question. Excellent. So let's have a look. I think that's basically everyone putting the right answer. Very well done. So side effects of drugs are something that's sort of useful to know with some of the drugs. And these are some of the, these are kind of some of the classic side effects of a beta agonist. Basically, because what a beta agonist is doing is, you'll learn more about this later, but you've got in your nervous system, you've got part of your nervous system that gets activated, your sympathetic nervous system, when you need to really get up and do something. If you're being chased by a lion, your sympathetic nervous system gets activated and does all the things to your body that you would need to do if you're being chased by a lion. And your beta agonists, your beta receptors are some of the main ones that get activated in that case. And one of the things that you need if you're running away from a lion is wide airways. So beta agonists cause your beta-2 agonists cause your airways to widen. And salbutamol, obviously, mainly beta agonists that are inhaled are going to your lungs, so that's good. We want those airways to be widened, but basically that inhaler can have effects outside of lung tissue, so it can activate your sympathetic nervous system in tissues outside of your lungs, causing those other effects that you might get if you're running away from a lion because of your sympathetic nervous system, like, you know, fast heart rate, you know, tremor because you're jittery, ready to go, that sort of thing. So this is just a summary table. We won't go through all of this, but these are some of the key drugs you need to sort of be familiar with for asthma. You've got your beta agonists, which sort of activate that, widen your airways by activating those receptors that you would activate if you were running away from a lion, those sympathetic nervous system receptors. You've got your antimuscarinics, which, so basically the opposite of the sympathetic nervous system is the parasympathetic nervous system, which is the one that gets activated when you're chilling out, when you're resting, when you're digesting food. And if you cancel that out, basically the parasympathetic nervous system does the opposite of the sympathetic one. So that's causing your airways to narrow, because you don't need to be breathing lots of oxygen when you're just chilling out on your couch. So antimuscarinics cancel out the parasympathetic nervous system, and so achieve a similar sort of result to the beta agonists. They widen your airways, and they also reduce your mucus, because when you're resting and digesting, you get lots of secretions that go on. So antimuscarinics will cancel that out, help to widen your airways by widening smooth muscle and reducing secretions. Okay, and your steroids dampen down your immune system. So pros are less inflammation, less swelling, less mucus, that kind of thing. And you get inhaled steroids that act mainly on your lungs, and you get systemic ones that you can use if the asthma is in a really bad attack. And that helps, but also has negative effects to do with, you know, causing more infections. If it's an inhaled one, it can cause like an oral sort of thrush type reaction in your throat. And if it's systemic, you can get sort of infections in your whole body, as well as other issues. And then leukotriene receptor antagonists also dampen down inflammation by their own kind of method, by blocking this kind of receptor that causes an inflammatory cascade. So next question. Okay. So you're all very, very good at your management of chronic asthma. You're so right. You add an inhaled corticosteroid. I think basically everyone but A for that. Really good. Basically, you need to be quite familiar with this management chart that I've stolen from the British Thoracic Society guidelines. And watch out for the nice guidelines, which are not the ones that the uni wants you to know, as far as I'm aware. And they're the ones that PassMed uses. So just watch out for that. Use the British Thoracic Society ones. Basically, if someone's using their so you start people off and they're just using their salbutamol beta agonist inhaler as required when they're feeling a bit breathless. But if they're having to use that 3 times a week or more, so me with my exercise-induced asthma, if I'm having to use my salbutamol 3 times a week or more, particularly if it's not just with exercise, if I'm using my salbutamol 3 times a week or more, my GP is going to consider putting me on a preventer inhaler. So that's the next step up, low dose inhaled corticosteroid. If I'm still using my salbutamol 3 times a week or more, they'll put me up again, and they might add a long-acting beta agonist, similar to salbutamol, but acts for longer. And this is something that you take every day. So after the initial salbutamol, these medications you put people on, and the steps up from this are regular inhalers that you take every day. So you're taking the inhaled corticosteroid every day. If that's not enough, you add the long-acting beta agonist that you take every day, and then those are the main things to know. And further up, in terms of further down the line management, it's useful knowing that, if the LABA and the ICS aren't enough, then you might consider increasing the dose of the ICS, or that's when you might add the leukotriene receptor antagonist, which is LTRA. But I wouldn't worry too much about that stage of management and beyond. The main things to know are salbutamol. If that's not enough, inhaled corticosteroid. If that's not enough, LABA as well. Okay, next question.
Also, just remember, if you have any questions as we go along, please do put them in the chat, and we'll do our best to answer them as we go along. Mm-hmm. All welcome. There's no such thing as a stupid question.
Okay. David and I are in the same place, if anyone was sort of wondering what's happening here. Yeah. Okay, so let's see what's happening on the chat. Got an A, a B, quite a lot of C's. Well done to the C's. The C's have it. This is a life-threatening asthma attack. Let's have a look at this. I accidentally added a transition on this slide. I don't know how I did it, but here we go. Okay, essentially what's happening here is, so if you've got any one feature of a more severe type of acute asthma, type of asthma attack, that asthma attack is classed as the more severe type. So here we've got a lot of features of a severe asthma attack. We've got a high heart rate above 100 beats per minute. We've got a peak flow of 35%. That's in the range of severe rather than life-threatening, which is below 33%. The oxygen sats are not below 92%, so that's not in the life-threatening category. But what we do have, sorry for all this flicking between things, what we do have is a silent chest. This is really worrying. This is telling you that airways are so constricted that they can't even get any. They can't really get any air through them. They can't even create a wheezing noise. They're just totally snapped shut. That's really worrying. And if we've got just that one feature of a life-threatening asthma attack, then this is a life-threatening asthma attack. Essentially, you'll just, from doing lots of practice questions, you'll just learn what the different key elements of the different types of different sort of severities of acute asthma are. Essentially, things to do with high respiratory rate and high heart rate and can't complete sentences in one breath are sort of severe criteria. It's worth remembering the peak flow. So if your peak expiratory flow, the amount that you can blow out at your sort of peak of blowing, so the amount that you can blow out quickly is 33 to 55%. That's severe. Below 33% is life-threatening. And then when you start to get systemic things wrong, like you're hypotensive, you're starting to get, you know, your consciousness is decreased, your heart's not working properly, it's going into strange rhythms, you've got and that sort of thing, then that's indicating life-threatening. It just seems worse, doesn't it? And when your oxygen saturation starts to go down, and then that's again life-threatening, because that's pretty bad. And then you're near fatal if your the concentration of CO2 on your arterial blood gas starts to go up, because that's telling you this person who is breathless. So if you're breathless, you should be blowing off CO2. CO2 should be low. If your CO2 is high, that's telling you this person's getting tired, and that's really dangerous. It's showing you they're struggling to breathe at all anymore. And obviously, if they require like something to ventilate their lungs for them, mechanical ventilation, then that's nearly fatal. Okay, next question. We're getting near the end of the asthma section now.
There's actually 2 B's here.
Oh no. Okay, well, you know what I meant. Type the answer that you know that I meant. C for inhaled corticosteroids, D for oxygen. Sorry for the confusion. That's my fault. Okay. Apologies for the confusion, everyone. The answer is the second B, which is C. The answer is C. Sorry for the people who put B. Everyone who put B, I know you meant C. It's my fault that you put B. Okay. Yes, inhaled corticosteroid is one of those drugs that we use in chronic asthma, but we don't tend to use it in acute asthma, because in acute asthma we're giving the systemic stuff. We're giving oral prednisolone or IV hydrocortisone, systemic steroids, because the situation is serious. This person needs help right now. We're not going to faff about with something that's just going to go to their lungs. We're just going to give it to their whole body. So basically, just worth being familiar with the drugs we give in acute asthma. Those systemic steroids, oxygen, obviously, that makes sense. We're kind of trying to keep their oxygen saturations up. And then we give them all the bronchodilators we can. We give them the beta agonist, salbutamol, in a nebulizer. So it's going all, so there's lots of it going to them. And then ipratropium as well. So that's the antimuscarinic. And then if the situation is life-threatening, then you start to consider, are we going to need mechanical ventilation? Are we going to need the ICU team involved? And then IV magnesium is the key thing to remember, as a step up from the kind of basic acute asthma management. IV magnesium if the situation is looking pretty grim. And then obviously you can give the other bronchodilators more frequently or continuously. Just worth remembering, like we were saying earlier, you can't just send your acute asthma patient home straight away. Basically, the way to help you remember what the patients need, what you need to do with patients before you can discharge them, is just think about what the objective is. The objective is we don't want this patient to just go home, get so totally forgotten by the medical profession and come back next week with an asthma attack. So we need to make sure they've got a follow-up arranged with their GP and with the respiratory clinic. We need to make sure they've been on their discharge medications already for quite a while, and we've checked their inhaler technique so we know they're in good stead for when they go home, to be keeping up with all of that. We need to make sure that they are well enough to go, so we need to make sure their peak flow is high, and they're not still really obstructive. We need to give them their own peak flow meter so they can check if they're in an asthma attack. They need an asthma action plan in place so they know what to do if they have an asthma attack. And we need to give them oral steroids for at least 5 days afterwards to try and cover them so they don't get another wave of asthma attack. Again, that sort of thing we were talking about earlier. Final question. I'm going to finish on a high with ABGs, everyone's favorite.
You've done A, B, B, C again.
Oh no, I think it's because I obviously like copied and pasted it or something. But you know what I meant. A, B, C, D. Okay. Well done to all of the people who put D. Yeah. Very well done. It's a respiratory alkalosis. That's what we have when we've got a high pH, and a low PaCO2. So with ABGs, there are different ways of learning, of getting your head around them. Some people will want to go through all, look at the equation and get their mind fully around the mechanisms behind it. Some people will just want a sort of short, quick, cheap way of doing it, which I've tried to sort of put here. Basically, if your pH is high, you've got an alkalosis. If your pH is low, you've got an acidosis. Okay, not too bad. The thing to look at for whether it's respiratory or not is look at the CO2. That's the key factor in your ABG that relates to whether it's respiratory or not. If CO2 is low, basically CO2 tends to drive the pH down. CO2 makes things more acidy, makes things more acidic. If pH is high, it tends to drive the pH down. So we know if the pH is low, so we've got an acidosis and the CO2 is high, then that is the CO2 causing the pH to be low. So we've got a respiratory acidosis. If your pH is high and your CO2 is low, we know that that is the low CO2 causing a lack of acidness, low acid situation. So the low CO2 causing the high pH. So basically, if the pH and CO2 are in opposite directions, that is a respiratory acidosis or alkalosis. In terms of metabolic things, key factor to look at is bicarbonate. That's what your body metabolism produces to try to make things less acidic. So if your bicarbonate is high and your pH is high, you know that that high pH is caused by your high bicarbonate. And if your pH is low and your bicarbonate is low, you know that low pH is caused by low bicarbonate. So if your pH and your bicarbonate are facing in the same direction, high pH and high bicarbonate, or low pH and low bicarbonate, you know that that is an acid-base imbalance caused by a metabolic factor. That makes sense. And then this, I'm not going to go through all of this now, but essentially this was me trying to explain ABGs to people who want to know more of the mechanism behind things. You can also get a mixed metabolic and respiratory acidosis or alkalosis and that sort of thing. And you tend to get your body compensating with the other one. So if you've got a respiratory acidosis, your pH is low and your CO2 is high. So we know they're pointing in the opposite directions. That's a respiratory acidosis. Your body tends to compensate metabolically by raising your bicarbonate a bit to try to mop up those hydrogen ions, make things less acidic. And so you say it's partially compensated if you can see that that bicarbonate is high, even though the pH is low. But if the pH is normal, but you've got high CO2 and high bicarbonate, then that's fully compensated because your body's managed to raise that bicarbonate enough to mop up all those extra hydrogen ions and the pH is normal. Okay, so that is the end of the asthma section. Do we have any questions on asthma before we crack on to David's section? I'll give 20 seconds, 15.
Basic little rundown of this week. So similar format to John and I. I'm just going to throw some questions at you and then we'll try and explain things as we go along. Please ask questions as we go along. And most of these questions I tried to cover like sort of the basic concepts that are in your labs. I've thrown a couple of hard ones in there, but for me, and I think this generally applies across GEP Year 1, if you can really get your head around the basic stuff really well, then you don't have to worry about the weird, complicated stuff, because you'll pass enough of the exam just knowing the basics. Okay, so have a go at this one.
Yeah, of course.
Okay, cool. So loads of people have answered C, and you're all incredibly clever because that is right. This is just one of those numbers that's worth having in your head, both for medical school and for the rest of your life as doctors, unless it changes. But just for now, it's 140/90, and anything over that on a regular basis, confirmed with sort of home blood pressure monitoring, is hypertension. So that's a good thing to know. Okay, second SBA, let's just crack on straight through it. Sorry, this is actually a horrible question. But a lot of you have said D, and you are right, it is D. This is, I actually completely had to work that one out then manually because I'd forgotten for a quick second. But basically, blood pressure equals cardiac output times total peripheral resistance. So this confused me for a while, and I thought I just had to sort of learn this equation. You sort of do, it's a good one to know, but actually, like, when you break it down, it makes a lot of sense. So your blood pressure is the same as your heart is pumping really, really hard, and it's pumping all this blood out, so that's your cardiac output. And then the amount of pressure that blood is under is going to be affected by the resistance in your blood vessels, namely the sort of the medium-sized arterioles. That's the main stuff that creates your peripheral resistance. And so if it's pumping against a lot of resistance, and you've got loads of cardiac output and there's loads of resistance, that's going to be really high pressure. If you imagine like turning the tap on full on your hose and then stamping on the hose pipe halfway through, the water's going to be under a lot of pressure there and might possibly burst. So, you know, you need to be careful of that. Hopefully that makes sense to everyone. If it doesn't, tell me I'm chatting shit and we'll go through it again. Okay, so basics for hypertension. Like I said before, so blood pressure that is consistently higher than 140/90 in clinic is hypertension. A good thing to be vaguely aware of is that there's a little bit of a lower threshold if it's measured at home, and that's because of the effect of sort of white coat hypertension, which is that some people are just terrified of coming to the doctor or to any healthcare professional, and their blood pressure just seems to be artifactually a little bit higher in clinic. But it's roughly the same. And they won't ask you mean questions between these two values. It's not fair. It'll be obvious in your exam questions. So hypertension is the biggest risk factor for cardiovascular disease, and it's also one that we can do something about. So this is why they love teaching us about it really early. Key sort of thing to be aware of, essential hypertension is what most people have. Most sort of older people, you know, with high blood pressure will have essential hypertension. That means it's just, they've got it. It just happened. It's idiopathic, if you like, although there are sort of a debated number of causes for it. But secondary hypertension is basically caused by a medical condition, caused by something that, if it is fixed, you can fix the hypertension. And you don't have to know loads about the causes of secondary hypertension at this stage, but it's useful to be aware of secondary hypertension as a concept, because they might ask you about it in the exam, or sort of ask you to differentiate the picture of someone with essential hypertension and someone with secondary hypertension. And I'll go a bit into that later. And then I've just put some other cardiovascular risk factors here. I don't know if you can see my mouse. I don't think you can. Oh, maybe you can. Okay, but it's just, yeah, I'll remember that. So yeah, other stuff, your classics: smoking, cholesterol, diabetes, etc. You can assess those with the Q risk score. If that comes up in your exam as to sort of how to assess risk factors, they love a good Q risk. Okay, so let's talk about Otis. So what most suggests that Otis is suffering from secondary hypertension? I'll give you a little bit longer on this one. Just wait for some answers to come through. Okay, so a lot of varied answers on this one. And this is a hard question because you don't learn a lot about secondary hypertension this year, but this is basically the most difficult question you'll get on it if it comes up at all. So I can understand why some of you are saying his ethnicity, because African heritage is a risk factor for essential hypertension, so sort of primary hypertension, if you like, hypertension with no cause, but not quite the right answer for this question. Again, hypertension is more common in men, so I can understand why people are saying his gender. If you said occupation, I just made that up. And asthma is not associated with high blood pressure, so it's not that. The key thing here is it seems obvious, it's like too obvious, almost like it's a trick, but it's his age. There's not that many 35-year-old people with high blood pressure. It's just uncommon. It gets exponentially more common after when you're sort of 50 and over, but below sort of 50, if it comes up in an exam question that a relatively young person has high blood pressure, as a medical student, as a sort of F1, as a GP, as a hospital doctor, you want to sort of be thinking, oh, why have they got high blood pressure? Is there something behind that I need to look into? So you might do a few more investigations than you would otherwise. So his age is the key thing here. And like I said, I think that is about as mean as that will be to you on secondary hypertension. I hope that makes sense. And here's an absolutely ghastly question, but I did these questions based on your lobs, and I thought I'll throw some Anthony Albert in there for you as well. I hope he still does your pharmacology lectures because he's a sweetheart. Sorry, I know we're not giving you a huge amount of time to answer these questions, and you have a little bit more time in the exam, so don't worry if you're not quite getting these within the time we're giving you. It's just because we're going to try and cram absolutely loads in into the time we're giving you. And Usman has just asked, how close are these questions to the actual SBAs in terms of difficulty? I've certainly tried to write mine based on what I remember from my GEP Year 1 exam and based on what I went quickly back over the practice questions we had in first year as well that they gave us. If you're finding these really, really hard, don't panic. You've got loads of time. This mock that you're going to have is just to assess where you're at now. And if you struggle with that, that's absolutely fine. It just means a bit of a reassessment on how you're doing things for the main exam. Loads of that's not a huge issue at all. By the time it comes to the main exam in January, you'll be much more prepared. If you're finding these easy, great, you're doing well, and I think you'll do okay in the exam. Okay, so the answer to this question is E, acetylcholine on M2 receptors. So M stands for muscarinic, which are like the receptors that you have in your parasympathetic nervous system. So acetylcholine is the big neurotransmitter of the parasympathetic nervous system, with a few exceptions, but don't worry about those. Basically, when you think about acetylcholine, think about the parasympathetic nervous system, and you'll generally be okay. So yeah, that's about all there is to say on that. It works on M2 receptors in the heart, and all it does is lower your heart rate. It doesn't do anything else. The parasympathetic nervous system doesn't have the power to control anything else, as I will hopefully explain a bit more in a sec. Oh, but not now, because it's another question. Bloody hell, I did too many in a row. Okay, have a crack at this one. I actually wrote this question based on my notes, and I had to Google it to make doubly sure I wasn't just speaking some quack science at you. But this is actually true.
I'd say this is quite a hard question.
This is really hard. Okay, so do not panic if this is not something that you're getting right. The renin-angiotensin-aldosterone, or the RAS, is something you'll come back again and again and again this year and like every year for the rest of your life. Loads of drugs act on this system, so it's don't worry if it's not sinking in now.
And this is about the nichest you could go on a question on the RAS system.
It's only niche because I was trying to, you know, lay the groundwork for explaining it. So the answer is, if you said C, well done, it's the heart. Why is it the heart? So basically, the RAS system does work on your arterioles because angiotensin 2 causes vasoconstriction. So when your blood pressure is dropping low, angiotensin 2 is released through the RAS system, and your arteries are sort of vasoconstricted, so they're squeezed, so they increase blood pressure. It does affect your kidneys because when your blood pressure is low, your kidneys detect that. Angiotensin 2 is released, and your kidneys retain more salt. And as you know from your osmosis week, where salt goes, water follows, and so you retain more water, and that beefs up your blood pressure. Angiotensin 2 also acts on the pituitary gland. It makes your pituitary gland release ADH. I don't know if that's ringing any bells for any of you. And that's your antidiuretic hormone, which, as well as it causing you to retain more water through a different mechanism in the collecting ducts of the kidneys, it also makes you more thirsty. So you're going to retain more water. And it also directly acts as another vasoconstrictor on your arterioles. And angiotensin 2 also acts on the adrenal gland, which releases aldosterone, that magical hormone, which also acts to retain more salt. So basically, you just got salt pouring in on all sides and water just being retained on all sides. Your RAS system is just a multitasker, and we'll go through that in a bit in a bit more detail. The way that I think about the regulation of blood pressure, and the way that I wish they taught you a little bit more clearly, is think about short term and long term. So in the short term, and this is breaking it down about as basic as you need to know, in the short term, your blood pressure is controlled by your autonomic nervous system, so your sympathetic and your parasympathetic. So you've got your baroreceptors, so your pressure receptors. Baro just means pressure, think like a barometer, in your major arteries, so your aortic arch, your carotid sinus. If the blood pressure goes up or down, your baroreceptors know about it straight away. It's very fast. They send signals straight away through your sympathetic and your parasympathetic nervous system, and they will speed things up or slow things down basically accordingly. So if the pressure is dropping low, your baroreceptors say, help, it's going too low, and your sympathetic nervous system sends signals to your heart to increase heart rate, increase contractility. Think of this poor little heart over here. He's having to work very hard. And it also acts on your blood vessels to just vasoconstrict, and so increase the pressure because you've got a tighter space, so it's going to be sort of higher pressure. And if the blood pressure is getting too high in the short term, your baroreceptors will say, hey, it's too high, and they'll send signals to your heart, and that will, as we said before in that question, release acetylcholine on your muscarinic receptors, your M2 receptors, and that will slow your heart rate down again. You might notice that this is slightly imbalanced. So the sympathetic does a lot more than the parasympathetic does. And that is, I can't talk to you exactly why the physiology of that is, but I just remember that it's a lot faster for you to get very scared and nervous and sweaty than it is for you to calm down from being scared and nervous and sweaty. It takes a lot longer. So if that helps you, great. If it doesn't, I apologize for waffling. So that's the short term, and that's really all you need to know, in my opinion. And I apologize if something more complicated comes in the exam. Long term, I apologize for this horrendous diagram that I drew. This is what I had in my notes actually from last year when I was going back over it, and I sort of broke it down as simply as I could get it. It probably could be more simple than this, but this is everything I was talking about earlier. So you've got your low blood pressure being detected by your baroreceptors and your macular denser cells in your kidney. And then you've got this release of renin, converted to angiotensin 1 by angiotensinogen, converted to angiotensin 2 by your ACE, which is really important for ACE inhibitors. And then angiotensin 2, like I said before, does all of these things, acts on these 4 places to have these effects. And basically, you don't need to know the effects in a huge amount of detail. You just need to know retains salt, retains water, constricts your arteries, blood pressure goes up. Don't panic and think you have to know this system inside and out. If you can know it well enough to know how the drugs work, you're doing pretty well. So if you understand that ACE inhibitors are going to inhibit this system and therefore lower your blood pressure, so by blocking this conversion of angiotensin 1 to angiotensin 2, which has all these effects, you're going to lower the blood pressure. Likewise, angiotensin receptor blockers will block angiotensin from having angiotensin 2 from having all these effects. And there's a few more things involved with renin and aldosterone that you'll cover later in endocrinology, so don't panic, it all comes back again. Secondary hypertension we already talked about, so I won't waste much more time on it. A couple of the common culprits here. Renal artery stenosis, so when your renal arteries basically are really constricted, and just like in this diagram, your kidneys thinks it's really smart, it thinks it's not getting a lot of blood, so it thinks the pressure is low, and releases all those hormones to try and raise the blood pressure, but that is counterproductive and makes the problem worse. Hyperaldosteronism is basically too much aldosterone, so again, back to your renin, you've got too much aldosterone, that's going to massively raise your blood pressure. I'm waving around a lot and I just realized my camera's off, so that's completely pointless. I don't know who I'm waving for. Pheochromocytoma, this is when you have it's the adrenaline tumor, which it might have come up a couple of times. This is incredibly rare, but for some reason medical school loves it. It'll come up this year, it'll come up next year, it'll come up every year of your life, basically because this is something you don't want to miss in clinic. If someone's got loads of adrenaline symptoms, like they're cold, pale, sweaty, heart palpitations, episodes of having these like really strong headaches, you're thinking about a pheochromocytoma, because basically this tumor is just releasing loads of adrenaline, so you're just getting bursts of, doom. Basically your body's just thinking it's dying periodically, and therefore it's got to run away from a lion. And then sleep apnea is another one, but don't worry too much about any of that. The main thing is young people. If you're young and you've got high blood pressure, think about something else. Or if someone's on like 4 different drugs and their blood pressure still isn't under control, think about an underlying cause. That's something to bear in mind. Cool, I've waffled for ages. Please enjoy another question. Okay, again, this question is a bit mean, and I don't think it would necessarily come up in an exam, but it's useful for like your understanding of how high blood pressure is investigated and managed. You might have heard about the target organ damage, which is something that really used to confuse me until someone explained to me that target organs are basically just the organs that doctors target with their investigations, because they're the ones that high blood pressure is going to mess up. And those organs, well done for saying, are so eyes, kidneys, heart, and blood vessels. And so that's where you want to focus your investigations for when you're sorting out someone with high blood pressure, and I'll explain that fully in a second. Jacinda is 70 and has come to your clinic. How do you proceed? Okay, excellent. The future of medicine is safe. You guys are amazing. So a few of you have said A, and I understand the instinct, because in reality, you probably would do this. However, there's a reason why A is not the best answer. In any normal situation, I work as a healthcare assistant part-time. In any normal situation, if someone's blood pressure measured this, I would just measure it again, because it's probably white coat hypertension. However, the key here is that you looked in the back of her eyes and she's got retinal hemorrhages and swollen optic discs, which you didn't know about before. So you must assume that these are as a result of the high blood pressure, and smash her straight on to a specialist on the same day, because this could be really life-threatening. I hope that makes sense as to why C is the better answer, because you don't want to wait around. You want to get straight on the phone and say, all right, I've got this lady with whopping high blood pressure that's so high it's causing her eyes, the back of her eyes to bleed, and the brain, her sort of intracranial swelling, which is what's pushing on her eyes and causing swollen optic discs. So yeah, that's quite worrying. It's quite a worrying situation. So that you don't have to know about too much about a hypertensive crisis, other than how to spot it, and they will make it very obvious in your questions. It'll be all of this: high blood pressure and target organ damage. So yeah, C. Well done. Okay, and like I said before, you've got to assess for target organ damage. So for the eyes, that's like in that previous question, a fundoscopy. So looking in the back of the eyes for signs of damage. And again, in the exam question, that'll be very obvious. To check on the heart, we do an ECG. So we could check for abnormal rhythms and anything else that's unusual. Check on the health of the blood vessels. We make sure they're not diabetic. We do their HbA1c. We check on their sort of lipid profile. We check their cholesterol. And if that's rubbish, we'll try and fix that. And we also check their kidney health as well. So we do a urine dip on the spot, because it's a really easy way to check for blood and protein, which is a quick on the spot check for any kidney problems. And we can also send off for some urea and electrolytes as well, which will tell us in a bit more detail if there's any problems with the kidneys. Hopefully all these terms mean something to you. If they don't worry, give it time, they will. Cool. Malignant hypertension, or accelerated hypertension, or hypertensive crisis are all kind of words for the same thing. This is where the clinic blood pressure is above 180 and you suspect something bad. So if there's nothing else going on and the patient's absolutely fine and isn't that bothered about the high blood pressure and you can't see any other signs, fine, it's not a hypertensive crisis. However, the key thing that I think they love to hammer home is bad eye signs, so retinal hemorrhages or papilledema, which is that swelling of the optic discs. Or if their blood pressure is above, if a blood pressure is like 220 and they basically turn up pale, on the verge of collapse, they've got chest pain, or they haven't passed urine in like 5 days, you're worried something's going on. Likewise, if they've got any of those pheochromocytoma signs, any of those crazy hyperadrenaline signs like shaking, sweating, pallor, headaches, chances are in your exam question, if there is one, it won't just be a very high blood pressure. That'll be something else to go along with it as well. Cool. I'll try and speed through these. I apologize, I'm running over a little bit. Giuseppe. Any more? Yeah, fantastic. Who is my favorite Spice Girl? Mel C. Amazing. You guys are cracking it. This is such a good basic thing to know. What you're going to start people on in terms of blood pressure management, and you guys all got it right. So we'll go into that in a bit, so I won't explain that now. Oh, well, we'll go into it now. Gosh, I've forgotten what I made these slides. Okay, so you'll have all seen something like this before. You divvy up your hypertension patients into young people and old people. And the young people get the same stuff as people who are type 2 diabetic, and the old people, and also people of Black ethnicity or heritage, they get the same treatment to start with. That treatment is your step 1. So if you're young or diabetic, you get A, which is your ACE inhibitor, or your angiotensin receptor blocker, depending on factors, but most of the time it's going to be an ACE inhibitor, to be honest. And if you're older, so over 55, or of Black ethnicity, you get a calcium channel blocker. They, FYI, won't give you a 55-year-old patient in the exam question, and they probably won't give you a patient that's too near the age of 55. It'll probably be quite obvious. So step 2, if that's not working out, you just add the other one. You can also, instead of adding the other one, you can add a diuretic. That will normally be because of contraindications to adding the other one. But that is something that is too complicated for them to assess you on really this year. So don't worry about that. Step 3, if both the two of them aren't working out, add diuretic, so you're on 3 drugs. And if that's not working out, add the beta blocker, or can anyone tell me why I've got this little picture up in the corner here? I haven't gone completely mad. Radio silence. Okay, I don't know if you're in Deepak's PBL group, you might have come across the mnemonic old black cat. I, as a rule, Bocan said it, perfect. So I generally, as a rule, hate mnemonics. I find them most of the time harder to remember than the actual thing itself. But this one is so nice for your exams. It's really easy. This is if you're older patient or a Black patient, you get C-CAT, calcium channel blocker. If you hate that, please ignore it. But if you find it helpful, then enjoy it. Hasnat says, would it be malignant hypertension if diastolic pressure was over 110, even if systolic pressure is not too high? Oh, that's a question for a specialist. In your exam, it won't be that. If your diastolic pressure was over 110 and you had new retinal hemorrhages or optic disc swelling that no one else knew about before and there's no note of, I personally would chuck them to a specialist same day and say, you know what, this is out of my league. But that is not going to happen in your exam in year 1, and it probably won't happen in my exam in year 3, and it probably won't happen in the final year exams either. So don't worry about it too much. Hope that's helpful. Okay, Winifred. Oh, got a big range of answers here. Exciting. Okay, so don't worry if you don't know this, because I didn't know this last year and it came up in our January exam. Oh, I shouldn't say that. It might have come up in our January exam. And I had no idea. But this is the big side effect for, well done if you said it, calcium channel blockers. It's just one of those, if you think of a calcium channel blocker, if you think it does anything, think about ankle swelling, because it's really common and it comes up a lot. So it's just a good one to know about. Okay, so they've done something about this ankle swelling. Okay. Sorry, I know I'm speeding through these, so apologies if you're not going to answer them in time. You will get all these slides, so don't worry, you can go over them again. So well done, everyone, because you all smashed it. It is ACE inhibitors, angiotensin converting enzyme inhibitors. Big side effect of those is they cause this dry cough. It's quite horrible, apparently. And interestingly, if you get a patient on ACE inhibitors who gets this dry cough, then you can actually just switch them to an angiotensin receptor blocker, so the B answer, because they don't cause the release of this, the buildup of this bradykinin, which is what people think causes the dry cough. So they just block the receptors instead. And so they have basically almost exactly the same effect, but without this horrible side effect. And the reason why we don't just prescribe it to everyone is, I think, just because they're too expensive. So yeah. Cool. Quick ECG interpretation. Ash is going to go through this with you much more, but I just thought I'd give you a flavour because it's in your lobs for this week. If you're staring at the screen and pulling your hair out in frustration, don't worry, because this was me when I was you last year. But don't worry, this will become slightly less like looking like alien hieroglyphs over time, I promise. Okay, I know I haven't given you a huge amount of time to go over that. The key thing that I want you to get out of this, which a couple of you did, so well done, and the only way you really get to know this is just by looking at a lot of ECGs, is that this ECG is normal. You would in real life have a lot more time to look through that, and you would in the exam as well. But what you can see here in most of these leads is this P wave, QRS complex here, and T wave here. And that is just the basic structure of your ECG, and you should be able to see that on the majority of the leads. It'll be upside down in AVR, but in all the other ones, almost all the other ones, you'll be able to see it. And there's no whopping abnormalities. I wouldn't be mean, I wouldn't chuck you one of those. And if they do in the exam, it's much more likely to be a heart attack, which Ash will go through with you later. So yeah, this is your normal sort of QRS complex ECG. Okay, almost done, I swear. And I apologise for doing another pharmacology question, but it's also in your lobs for this week. Unless they've changed it since we did it. Wow, I actually can't believe how many of you have got everyone who's answered in the chat has got this right. That has been insane. I struggled to understand this last year, so well done. It is greater bioavailability. So that is why we like IV drugs, because they're by nature 100% bioavailable. Bioavailability is the amount or the percentage of the drug that is after consumption of it or after administration of it is available in the bloodstream. Obviously, if you put it straight into the bloodstream, it's all available in the bloodstream. So it's 100% bioavailable. So it's going to have a much quicker action, which in this instance is exactly what you want. The other sort of phrase to know here is volume of distribution, which isn't super relevant in this because we're just talking about speed. But volume of distribution is how you've been explained, is how much a drug distributes through the tissues of your body after you administrate it. So if it distributes loads, it's basically going to places you don't want it to go. And so you need a higher dose of it for it to have the same effect. Whereas if it's got a low volume of distribution, it's not distributing very much. It's mostly staying where you want it to go. And therefore you can get away with a lower dose, if that makes sense. That took me a long time to get my head around, but actually that is quite a simple way of thinking about it. Last question. Cheeky bit of anatomy. Look right at the point of the arrow. A lot of D's, some A's, and a B, another D. Okay, so well done everyone who said D. I know this is, if you're looking on a tiny screen, this is probably horrendous, and you're going to feel like you've cheated. This arrow is supposed to be pointing to this sort of white cord-like structure here, which is the Chordae Tendonite, which is the bit that holds the sort of straps the valve to the papillary muscle, which are these ones down here. So that's what it would be pointing at if it was the papillary muscles. They don't just love this for no reason whatsoever. It is clinically relevant. You just don't have to know why it's clinically relevant at this stage. Basically, all of this can just rupture and go horribly wrong after you've had a heart attack. But don't panic about that now. You're only in first year. It's fine. So it's just, these are the Chordae Tendonite. David Sunnux, if he still teaches, loves these, but I actually think he's left now. But he used to say it was like the parachute strings holding onto the parachute, which is your valve. So if that helps you, great. If it doesn't, don't bother. Chuck it away. So yeah, Chordae Tendonite, well done. That is it for hypertension. Here's some heart anatomy. I wasn't going to bother talking you through this because, to be honest, you don't have to know it in a huge amount of detail, is the point I was trying to get across. If you're looking up the names of like microscopic veins and arteries, you're going too far. Just the main big structures, the main big arteries and the main big veins will do you absolutely fine. They just absolutely love Chordae Tendonite and papillary muscle, and that's why I chose to include them. Okay. And this is a really lame meme about ACE inhibitors. So does anyone have any questions about hypertension? I'm sorry, because I've gone on way over.
So I'm Anea. I was a GEP at George's and I'm now F1 at George's. So I'm around if you guys ever, I don't know, need any help, need a pep talk or want to grab coffee or whatever. I'm still at George's, so just let me know. So we're going to start by, if my slides will change, going through some of the pathophysiology, and then we're going to go on and just talk through a case. So first thing for this week is knowing a bit about what happens when a vessel gets injured. So first thing that happens when you get vessel injury is the vessel will constrict, and that is to kind of try and reduce some of the blood loss. And then secondly, you get what we call primary hemostasis, which is where you get this formation of quite an unstable platelet plug. And that happens, firstly, there are like a couple of steps. So the first thing is platelet adhesion. So that's when von Willebrand factor, which you don't need to know too much about, but just know it exists, helps to bind platelets to any exposed collagen on the vessel. Then you get platelet activation, and that's when the platelets change shape and they kind of release lots of different chemicals that cause kind of vasospasm, so kind of constrict the vessel even more, and also kind of recruit other platelets. And then thirdly, you get platelet aggregation, which is where all the platelets basically clump together and form this clot that kind of seals off the area. And so that is primary hemostasis. And after that, because the platelet plug isn't particularly stable, you need to kind of stabilize it with what we call secondary hemostasis. And that's when you activate the clotting cascade and stabilize the plug with this fibrin mesh. And then later on down the line, when the vessel's repaired, you're going to kind of dissolve the clot. And that's kind of, you just know it happens. You don't really need to know loads of detail on that for GEP Year 1 or any of it really. So the coagulation cascade. So when a vessel wall gets damaged, something called tissue factor is released, and tissue factor is also called factor 3. And that's what sparks off the extrinsic pathway. And that's kind of the quicker pathway. So the extrinsic pathway happens first. And factor 3 even then activates factor 7, which then goes on to activate factor 10, which then converts kind of prothrombin to thrombin, and then thrombin converts fibrinogen to fibrin, and fibrin kind of polymerizes into these chains, which are then cross-linked by factor 13 to kind of stabilize the clot even more. So that's kind of the extrinsic pathway. The intrinsic pathway is a bit slower to start acting, but factor 12 is activated by kind of platelets, by exposed endothelium, and by collagen. And then factor 12 goes on to activate factor 11, 11 activates factor 9, and 9 activates 8, and 8 activates 10. And then when you get down to 10, kind of the pathway at the bottom, that's what we call the common pathway, because it's common to both the intrinsic and the extrinsic pathways. I never really figured out a fun way, I don't know Ash if you did, to like remember the different what goes which side. I just had to sit and memorize it. So I don't know if any of you have any fun, but
yeah, I mean, for intrinsic pathway, I always start with 12, and then I grab the last letter of the word 12. Then it's like 11, ends in N, so it's 9.
Oh, that's so cool. I wish you'd told me that in GEP Year 1. Cool. You just kind of have to sit and memorize it. But yeah. So the next thing they kind of want you to know a little bit about is clotting tests. So you've got your APTT, which measures your intrinsic pathway, and your PT, which measures your extrinsic pathway, and I remember which one's which by play table tennis. So you play table tennis indoors, so that's intrinsic, and then play tennis, which you do outside, so that's extrinsic pathway. And then you have your thrombin time, which kind of measures the conversion of fibrinogen to fibrin. PT is always quicker than the APTT. And they kind of occasionally ask questions in GEP 1 about kind of mixing studies, which are studies you can do to work out whether a patient is kind of deficient in a factor or whether there's something inhibiting the process. So what you do is you mix equal amounts of the patient's plasma and some normal plasma, and then you repeat the abnormal test. And if the result normalizes, then that means that there was a factor deficiency, and all that was going on was that there wasn't enough of that factor. Now you've added in some normal plasma, there's enough of it and it's normal. But if it stays abnormal, it means there's something inhibiting the process. So there's probably an antibody or something else going on that's a bit more complicated than just a deficiency. Okay, first question, what is the mode of action of rivaroxaban?
So we're getting a lot of C's coming through.
Ah, perfect. Yeah, so C is the answer. So you don't need to go into lots of detail, but I think it's just worth kind of knowing a little bit about how the different drugs work. So the cheat way is with rivaroxaban, and with a lot of the DOACs, they actually tell you what factor they act on in the name, which I didn't realise for ages, but rivaroxaban and apixaban have an XA in the middle, so they act on 10A. And then if you look at the thrombin ones, like dabigatran has a TR in it, which helps. And then you've just got your anticoagulants, you've got antiplatelets, so things like aspirin, clopidogrel, and then thrombolytics as well. It's just worth knowing kind of where they all sit, but you don't need to know too much. So coming on to talking about PE. So the definition of a pulmonary embolism is an occlusion or obstruction of the pulmonary artery and or one of its branches. And emboli can be lots of different things. So there's a neuronic FAT, which stands for fat, air, thrombus, bacteria, amniotic fluid, and tumour, which are all the different things that can cause emboli. But when we talk about PEs, it's pretty much synonymous with just being a thrombus. And when you think about the risk factors for PE, you need to think about Virchow's triad. So that is stasis, hypercoagulability, and vessel wall injury. So in terms of stasis, it's things like if someone's been immobile, so they've had like a long stint in hospital or been unwell and on bed rest for ages. If they've travelled really long distances, although there's a bit of debate about kind of whether that is a significant risk factor or not, but I think generally for SBAs definitely is a risk factor. Vessel wall injury, so if they've had recent surgery or if they've had like a lower limb fracture or any trauma to the lower limbs, that's a big risk factor. And then hypercoagulable states, so if they have active cancer, if they're on the combined pill, if they're pregnant, or if they have any kind of thrombophilias. And then another kind of big factor to think about outside of these is just if they've had a previous PE or DVT, then it kind of suggests that they might be quite prone to them. So a DVT is a clot in the lower limbs or upper limbs, and symptomatic PEs are associated with DVTs in up to 80% of cases. So usually when you have a PE, it has come from like a venous thrombus. But that being said, DVT is only symptomatic in about 25% of cases. So if you have a patient come in and you kind of look at their lower limbs, there's no obvious signs of DVT, it doesn't mean that they're not going to have a PE. And then in terms of symptoms to look out for, so if they've got unilateral leg pain, any swelling, any warmth, any erythema, then they're the things to think about. When you're kind of stratifying the risk for DVTs, there's a Wells score, and there's a Wells score for DVT and a Wells score for PE. So just remember there are two different ones. In terms of the Wells score for DVT, I would say you don't really need to, well, for both of them, to be honest, you don't really need to memorize the actual score. Like, I don't think they would ask you a question to actually calculate the score, but it's worth just kind of remembering what factors are involved in it. So it's things we spoke about before in Burkell's triad. So active cancer, immobility, signs of a DVT, and things like that. And once you've worked out the Wells criteria, it's stratified into kind of low risk, moderate risk, or high risk. And then that will decide on your management. So if they've got a low Wells score, then you go on to doing a D-dimer. And if that's negative, then it's very unlikely that they've got DVT. If it's positive, in this diagram it says treat for DVT. I think in reality you'll probably still do an ultrasound. And if DVT is likely, so high risk on the Wells score, then you're going to go on to do an ultrasound. And if that's negative, you'll do a repeat ultrasound. If it's positive, then you're going to treat for DVT. And when I say treat for DVT, rivaroxaban is the first line treatment, and you normally will continue on rivaroxaban for at least 3 months. So we're going to move on to our case now. So Mrs. Smith is a 30-year-old woman who comes into A&E complaining of chest pain on inspiration and shortness of breath. She has recently returned from her honeymoon in Fiji. She takes the combined oral contraceptive pill, but no other medication. She also mentions her left calf feels tender and it looks quite swollen. So what investigations would you like to do next? I'm afraid it's not an SBA, it's just a...
So we've got Wells score, lower limb ultrasound, CTPA.
Yeah, nice. There are some probably more obvious things you'd want to do first, but they're all good suggestions.
Okay, I just got a couple more ultrasounds, one D-dimer, duplex ultrasound.
Ooh. Yeah, there are some very simple things that you guys would probably do first, and I'm sure you know, but
think about by the bedside kind of things.
Yeah, like for pretty much every patient who comes in, you would do these things.
So we've got ask if she's ever had a DVT before, vitals.
Take a good history. Vitals, yep, exactly, OBS. Someone's mentioned CTPA, but there's probably an imaging that you'd do before jumping straight to a CTPA.
Chest X-ray, got that.
Yeah, perfect. And then aside from D-dimer, after you've done your Wells score, what other kind of blood tests do you think you'd take?
Got a couple other responses. So got an ABG, FBCs, someone's wrote dorsal flexion as well. I'm not sure that's relevant here.
But yeah, definitely full blood count. So I was thinking observations, do an ECG, chest X-ray, a full blood count, some U's and E's, LFTs. Sorry?
Got clinical exam coming through as well.
Yeah, perfect. So definitely going to examine her. And an ABG is a very good suggestion as well. Cool. So you've done all those tests. What is the most likely ECG finding if Mrs. Smith does have a PE?
Just give it a couple more seconds for more answers to come through. but we're getting C's so far.
Okay. Give it 5.
Got a D, got 1 D. Got a couple of D's now.
Cool.
Got a few more C's.
Cool. So that's kind of the split I was thinking. So the answer actually is sinus tachycardia. So I feel like in, I don't know, past med and books and things, they really talk about this S1Q3 T3, which you do get in PEs, but the most common is actually sinus tachycardia by quite a long way. And this is what an ECG of S1Q3 T3 does look like. So you have S waves in lead 1, Q waves in lead 3, and then inverted T waves in lead 3 as well. But it's not something to kind of look at the ECG, and if they don't have it, it's not a PE. It's kind of only about, I think it's less than 20% of people with PEs will actually show this pattern on their ECG, whereas sinus tachycardia is a lot higher. I think it's around 50% of them will have just sinus tachycardia. So results come back. So you've done your observations. Just got a heart rate of 110, blood pressure of 110 over 80, temperature 37.8, and oxygen sats of 92% on room air. Her bloods all come back normal, and on her ABG you notice that she's got low oxygen and low CO2. So is that a type 1 or a type 2 respiratory failure?
Got a couple type 1s. Got a few type 1s coming through.
Cool. Yeah, perfect. So it's type 1. So in type 2, you get kind of the increased CO2 is the characteristic thing. And the ECG comes back showing sinus tachycardia, and the chest X-ray is normal. So the chest X-ray is actually done to kind of rule out other differentials. So you're not really expecting to see anything on a chest X-ray in PE. But do you guys know what other differentials you can kind of rule out if you get the chest X-ray back and it looks completely normal?
So got pneumonia as a suggestion. So
yeah, perfect. So there are 2 main ones, so pneumonia and one other cause of chest pain that you can normally see on it.
Pleural effusion, got pneumothorax.
Yeah, perfect. I was thinking pneumothorax, but yeah, pleural effusion as well is a good answer. And then this chest X-ray in the background is just one of the characteristic things they talk about for chest X-rays in PE, which is this like wedge-shaped effusion called a Hampton's hump. But again, they're actually quite rarely seen. So it's one of those things a bit like the ECG S1Q3T3. You can see it, but again, if the X-ray is normal, it still does not rule out PE. So the next thing, so you're going to calculate your Wells score. And so the kind of criteria for the Wells score is if they've got clinical signs and symptoms of a DVT, that gives them a score of 3. If their heart rate is greater than 100, that gives them a 1.5. If they've had kind of any immobilization, if they've got hemoptysis, they've previously been diagnosed with DVT or PE, if they have malignancy, and if an alternative diagnosis is less likely than PE, that's another 3. So you calculate their Wells score. In our case, our lady had clinical signs and symptoms of a DVT, and her heart rate was raised, so she'd score 4.5, which makes PE likely. And then you go on to kind of using this flow diagram. If there's kind of low probability of a PE, so the score is less than 4, that's when you're going to go on to do your D-dimer. And it's kind of really important that you only do your D-dimer if there's a low probability of PE. So I actually got this wrong when I was on call a few weeks ago and got in a bit of trouble because I didn't order a D-dimer because her Wells score was low, but it's actually the opposite. So you need to remember that D-dimers can be raised for loads of different reasons. So if there's kind of any kind of inflammatory type state, if they've got malignancy, there are lots of different reasons for having a raised D-dimer. So you should only use it if there's a low probability of PE to help rule out PE. So if the D-dimer is negative, if it's low, then it's quite a good sign that there isn't a PE. But if it's high, it actually doesn't massively help you. So if the D-dimer is then positive, then you'll go on to investigate and do a CTPA. And then down the other line, if your well score is really high, then you're just going to go on to do a CTPA. And you don't even really need to worry about the D-dimer.
We got a couple of questions here.
So
the first one is, do we need to know things like Hampton's Harm, watermark, Westermark's sign, etc.?
I'd say know them in terms of like, know they exist, but I wouldn't worry about them. Like, I can't actually remember what the watermark or whatever, Westermark. I can't remember what that looks like, and I can't remember that ever. I don't know if you can, Ash, but I don't remember ever being tested on that.
I don't think so either. I think it's just
the wedge-shaped one like this occasionally, so the Hampton's Hump. But again, like, I wouldn't stress about it, and the chest X-ray is usually normal.
So second question is, do we need to memorize the risk factors and scores in these tests? So the PE well score, risk factors and scores, or would they be given in the exam?
I think know the kind of principle behind it. Let me know if you disagree, Ash, but I would say I don't think they ever asked us to actually calculate the score.
Yeah, the well score, I don't think you have to calculate. I think it's just kind of knowing how it works and what it indicates and what your next step would be, kind of thing.
Yeah. Were there any other questions?
No, that was just those two.
Cool. And so then in Our Lady's case, she had a high well score, so she would go on to have a CTPA. And I just thought it was good to include what it would actually look like. So with CT scans, you need to imagine you are standing at the end of the bed at the patient's feet and like looking upwards, because that's how the scans look. So on this side, the right side is actually on the left side of the screen because you're standing at the feet, if that makes sense. And the picture on the left-hand side, I've circled what a clot would look like on a CTPA. So they're the pulmonary arteries, and that's a clot in one of the pulmonary arteries, in the right pulmonary artery. And it's just good to kind of be a bit familiar with kind of the anatomy on a CTPA. So in terms of management of PEs, so rivaroxaban is usually first line, and you give 50 milligrams twice daily for 3 weeks. And then after that, it drops down to just a maintenance dose of 20 milligrams once daily. There are a few exceptions. So if the patient is at really high risk of death, so they're looking really unwell, their blood pressure is awful, their heart rate's really high, really poor oxygen sats, then you're going to give them IV heparin and a thrombolytic agent as well, so either alteplase or streptokinase. And that's just because you're not so worried about the risk of bleeding because they're so unwell with the clot that you really need to get rid of the clot. And then the other exception is if they've got active cancer or are pregnant or breastfeeding, then you're going to give them low molecular weight heparin instead of the rivaroxaban. And then other final thing to know is that if they have had a PE and it's unprovoked, so there's no obvious reason why they should have had a PE, then you need to investigate for why that might have happened. So investigate for malignancy, investigate for antiphospholipid, and investigate for any thrombophilias as well. And everyone who's had a PE, when they're discharged from hospital, they get seen in an anticoagulation clinic, and they'll kind of do tests for those different things. And that is everything for PE. So the other few things I didn't go through is the pulmonary vasculature and the anatomy, and then just know a little bit about fibrinolysis as well. But thank you for listening. Are there any other questions beforehand?
So my name's Ash. I'm an F1 doctor in Ealing Hospital. I was also at George's and just graduated. I've also put my email down here in case anyone wants to contact me with any questions that you may have. Occasionally might pop into George's here and there to do some clinical skills teaching, but apart from that, I'm usually on the other side of London. So let's get started. So we're starting with an SBA. So which of these vessels supplies majority of the septum? If you put the answers in the chat.
So we've got lots of D's coming in.
Okay.
Yeah, still more. Everyone so far's put D.
Okay. Any more coming through?
No, I think that's it now.
Okay, cool. So the answer is D, so well done. So if you look, so I'm not going to go through all of the anatomy, but I'm just going to kind of go through it and kind of map where the arteries are and where the structures are. So you can see the septum's kind of coming in the middle here. And if you look at where the LAD, so the left anterior descending artery comes down, it's kind of in the place where the septum would normally be. You also get some supply from the RCA, like the posterior part of it as well. But the majority of it is the LAD. Next, SBA. Which ion is involved in cell membrane depolarization?
Cool, so we've had still some more answers coming in, but lots of A's.
Okay, cool. So A is the correct answer. Well done, guys. So just to quickly go through action potentials. So you need a sufficient amount of stimuli to get the membrane potential to the threshold. So it's usually around -55. So -70 is the resting potential, -55 is like the threshold. And once it hits that threshold, then a cell membrane starts to depolarize. Then the sodium channels are what kind of flow in first. So these are going into the cell, depolarizing the membrane, and that's going through the voltage gated sodium channels. Once it reaches about +30, these sodium channels close, and this triggers the voltage gated potassium channels to open and gets the potassium to go out of the cells. And this part is called repolarization. So it's trying to bring it back down to the resting potential. But what happens is it overshoots a little bit and goes down to -90 instead. And this is really important because it gives you a little gap to kind of reset everything. So you get your sodium and potassium pumps just kind of switching them around, so it can slowly hyperpolarize and bring it back to rest. So you have most of your sodium outside the cell and more potassium inside your cell. And then the cell's ready again for the next action potential to go through. So next SBA. So which ion channel is involved in maintaining cardiac cell membrane potential during cardiac contraction?
So we've got a couple of answers coming through. We've got a mix of E's and D's. Mainly, a mix of E's and D's.
Okay, had a feeling it would be like that. So the correct answer is E. So I used to get confused with this as well. It's pretty much just trying to rote learn. So you've got your pacemaker cells and you've got your cardiac cells as well. So the question here was asking during contraction. So this is what's maintaining that contraction and allowing the muscle to continue to contract. So it's the L-type channels for that. So that's this phase here. So your phase 2 is where you have the L-type channels open and the calcium keeps going in, and this kind of balances out with the potassium channels which are open and trying to depolarize the cell. So instead of depolarizing it, it keeps it polarized and allows the cardiac muscle to continue to contract, which allows you to eject the blood out of the heart. Just to kind of briefly go through the whole thing, I'm just going to run through it. So with your pacemaker cells, you start off in phase 0, where you have the opening of the L-type calcium channels, and you have the calcium going in, so that kind of depolarizes the cell. Then these channels close and your potassium channels open. That leads to an influx of your potassium ions. Then you have this kind of slow depolarization as going on in the background due to these slow, like sodium channels, which is kind of, it's in the background, so you don't need a stimuli, it just happens automatically. And that's why they're called pacemaker cells, because this kind of keeps the heart beating and keeps the action potentials going through the heart without any other stimulation. Okay, and then your cardiac muscle cells, you've got your fast sodium channels in phase 0, which open, and this is what depolarizes the cell. And then in phase 1, it's starting to repolarize, but then phase 2 kicks in really quickly, which allows it to kind of balance out and continue that contraction without repolarizing. Then it gets to a point when it's fully contracted, where you get the rapid repolarization because these calcium channels just close, and the potassium channels just continue to stay open to allow it to reach its resting membrane potential. Cool. And I'm just going to quickly go through the cardiac conduction system as well. So the pacemaker cells sit in the sinoatrial node, and this sends a signal to the atrioventricular node, and this then sends your signals down the bundle branches here, so your bundle of His, and you've got your right and left here, and then these kind of branch out into the muscle and stimulates the muscle cells, the cardiac muscle cells, to contract. Yeah. So we've got an ECG here, so just have a look at it and just put in the chat what you think it shows.
Sorry, I forgot it was up to me to. So we've got quite a mix actually. So I'd say majority A's, but also some D's and some C's.
Okay, so the answer is A. So the main thing with the fact that it's sinus is that there's a P wave for each QRS complex. So it's not really an arrhythmia as such. And I can see why someone might have put an anterior STEMI because these look a bit tall, but that's not really a STEMI, and I'll go through the STEMIs in a little bit. So the ones that you'll get in exams will be very much textbook classic what a STEMI should look like. So just to kind of go through the quick basics of ECG. So your rate is worked out. So there's two ways to work out your rate. So first way is dividing 300 by the number of squares between each QRS complex. Or what you can do is, if I go back to this rhythm strip at the bottom is about 10 seconds. So if you got someone with an irregular rhythm, one of the best ways to work out their heart rate is by counting the number of QRS complexes going across. Because it's in 10 seconds, you times it by 6 to get your minute heart rate. Okay. So the rhythms, So the rhythm is determined by the intervals between the QRS complex. A good way of doing it is getting a piece of paper, putting it over the ECG and just marking the gap and seeing if it matches up with the other gaps between each QRS complex pairs. And this will help you kind of identify if it's a regular rhythm, so if they're equal gaps between each of the QRS complex, or if it's irregular. And the other thing you want to kind of differentiate is if it's regularly irregular. So if the gap between the QRS complex differs, but it has a pattern to it, then it's regularly irregular. If there is no pattern to it, then it's just irregularly irregular. And like I mentioned before, you want to make sure each QRS complex has a P wave, this little hump there, just before it. The next thing that you normally look at is your axis. So this table is just an easy way to kind of remember it. So the two leads I normally look at would be lead 1 and lead ABF. I think some people also look at lead 1 and 2 or lead 1 and 3, but this is what I found best works for me. So I'll go through the anatomy a little bit whilst I'm going through the table as well. So for a normal axis, lead 1 and lead and ABF will both be positive deflections. So the QRS complexes will be pointing up. And if you look at this diagram here, I'm hoping you can see my mouse. So you got your lead 1 picking up all the current going this direction to the right. And then you've got ABF picking up all the current that's going downwards. And your current in the heart is going kind of just in between both of them. So it's going towards both leads, therefore both of them are going to be positive. With a left axis deviation, your lead 1 will be positive, so still pointing up. ABF will be negative, so pointing downwards, so they're pointing away from each other. So the way I remember is they're leaving each other, therefore it's left. And just kind of to look at it anatomically, you've got the current kind of going more towards lead 1 because it's deviated towards the left. So lead 1's going to remain positive, but it's away from ABF. So it's almost like it's going away from it. So that's why it's negative. And then the opposite happens with a right axis deviation. So lead 1 is negative and ABF is positive. And these are pointing towards each other, so that's right axis. So if we look at the diagram again, the right axis means it's more towards ABF. So more of the current is going in the same direction as ABF. Therefore, that's still going to be positive, whereas its majority of it is going away from lead 1, which is why it's negative. And then you've got this thing called extreme axis as well, which you don't really need to remember, but it means lead 1 and ABF are both negative, and it's a very, very rare thing to see. Okay. So just kind of quickly going through what's happening in an ECG itself. So your P wave over here, that is your atrial depolarization. So that's what's happening at the sinoatrial node. Then you've got your kind of QRS complex here, which is the depolarization of the ventricles. And this gap here, the PR segment, is your kind of depolarization of the AVN itself, getting ready for the ventricles to depolarize. And then you've got your ST segment here, which is your ventricular depolarization. repolarization, sorry. And then you've got your QT interval here, which is your depolarization and your repolarization. The main things that you really need to know is just this: it's the P wave followed by a QRS complex, and then you've got your T wave after that. Okay. We've got another ECG here, so have a look at it and have a go at guessing what it's showing.
Just going to wait for a few more answers to come through.
Yeah, that's fine.
So we've got mainly C's and a D as well.
Okay, so C is the correct answer. Oh, it's E. Sorry. So if you look at leads 2, 3 and AVF, you can see T-wave inversions here. I think people are thinking it's an anterior STEMI because of this here. So it's not quite a tombstone-y kind of shape there. So this would just be kind of a normal T-wave. So I wouldn't be too worried about this. It's these leads here where you can clearly see there's an inverted T-wave, which indicates an N-STEMI, and these are the inferior leads. Okay, so just to kind of go through identifying an NMI on an ECG. So this is what a normal ST segment looks like. So you can see this bit here is the key bit that we want. And if there's a bit of a flat line there, then it means it's not elevated. In a STEMI, this whole bit is coming up, and you can see it's from the end of the QRS complex, it's kind of starting to form this kind of tombstone kind of shape. With an N-STEMI, you've got two different types of N-STEMIs. So the one that we saw in the SBA was this T-wave inversion. The other one is the ST depression, where the line where the ST segment is, it's kind of pushed down instead. So it's kind of like a deep bit after the QRS complex. Then we've got the different territories that you need to remember as well. So the inferior ones are your leads 2, 3 and AVF. And this inferior part is supplied by your right coronary artery. Then you've got your anterior septal, which is supplied by the LAD. So you've got V1, V2, which is mainly the septum, and V3 and V4, which is the anterior part of the heart. And then you've got your lateral leads, so lead 1, AVL, and then V5 and V6, which are your lateral leads. And this is supplied by the circumflex artery. Got another ECG for you here.
Just going to give people a bit longer.
Yeah, that's fine. How are we doing for?
So we've got mainly B's and some C's.
Okay, cool. So the answer is B. So this is a normal ECG. So I can see that some people are still falling for this trap of an anterior STEMI. So if you look at this ECG, you can see the QRS complexes are negative. That's normal. So it's like a normal progression. So it starts off negative in V1 and then starts becoming more positive by the time it gets to V4. This line here, this is your T wave. And if that was a STEMI, that would be elevated from this point here where the QRS complex ends. But it's not, so it's just a normal T wave there. And this is just a normal ECG as well. So try not to fall into that trap of looking at that T wave and thinking it looks a bit too peaked. I picked this one on purpose because the T wave looks a bit odd, but it's actually not. Okay, so I'm just going to quickly go through the cardiac cycle as well. So this is something that always kind of baffled me a little bit, so I just end up going over it again and again. So systole is when your heart's pumping out the blood, and diastole is when it's kind of relaxed and starts filling. So if we start over on this side, so you've got your mitral valve opening, so this is what allows the blood to flow into the ventricles. So as it's filling, your heart's also relaxing, it's filling, 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 and the mitral valve closes. At this point, your ventricles are starting to contract, and it increases the pressure in the heart. And as that increases, then at this point, your aortic valve opens, and then whilst that's open, it's pumping out the blood, but at the same time, the ventricles are contracting as well, which is why the pressure in the heart increases a bit more. And then as it's losing the volume, the pressure starts to decrease. Aortic valve closes, and just remember there is this residual volume left over in the heart as well. So that's going to create a bit of pressure. And then your pressure starts coming down as the heart muscles relax. And then this starts all over again. And your heart sounds kind of correlate to B and D here, where your mitral valve closes, aortic valve closes. So you get S1 and S2. So just to quickly go through ischemic heart disease. So you've got two different types. So you've got your angina pectoris. So you can either have stable angina or unstable angina. So stable angina is when you get chest pain on exertion most of the time, and it's usually relieved once you start resting, or if you have take some GTN. Unstable angina is is when you get chest pain at rest, and sometimes it won't go away with your GTN spray. Myocardium infarctions are more serious versions of this, where you end up with a block and it leads to ischemia of the heart muscles. And then you have two types, so your STEMI and your NSTEMI, which are classified by the changes seen on the ECG. So your STEMIs are usually the more serious ones. So how I remember is your NSTEMI comes along first, and then it can develop into a STEMI, which is a bit more serious. And all of these are due to a blockage in the coronary arteries. And most risk factors are increasing in age. It's more common in males than females. So usually in females, I think you're more likely to have a heart attack after the age of like 65, 70. And in males, it's usually at a younger age, so around 50. Obesity, smoking, hypertension, high cholesterol, and diabetes are all other risk factors as well. So just to kind of go through what's happening in your arteries itself. So just imagine someone with a very high fatty diet, and this all needs to go somewhere. So this is all traveling around in your bloodstream, and then it starts forming these kind of fatty streaks because they start getting stuck to the walls of your artery. This over time starts accumulating, and then you've got your macrophage which want to kind of clean this all up, but instead what happens is they start forming these foam cells, and this all gets stuck within the walls of the artery, and they form plaques. And once they form these plaques, they can be stable, but sometimes they can kind of rupture and form a thrombus and start blocking off the whole artery. And this is what kind of leads to MIs and unstable angina and things like that. So I quite like this infographic here. So you can see here, the blood's flowing, but these plaques are kind of blocking the flow of blood in the artery from the blood clot, and also kind of the growth of the plaque as well. And this is also why it causes increase in blood pressure, because you've got more resistance in the arteries itself. Okay. So your next SBA, you've got a 59-year-old Caucasian woman who comes into the GP complaining of recurrent chest pain and shortness of breath over the past 6 months, mostly when she's climbing the stairs and walking into work. The pain goes away once she's at rest. She works in a call centre and enjoys her donut breaks every hour. She claims she is fairly healthy. What is the most likely diagnosis?
So, still more coming in. It looks like mainly A's and a couple of B's.
Okay, cool. So A is the correct answer, so stable angina. So she's complaining of chest pain when she's kind of moving around, so climbing the stairs, walking into work, things like that. And then the pain's going away when she rests, so that indicates stable angina. If she was at rest and she was still having chest pains and they weren't going away, then we'd consider like unstable angina, potentially an MI kind of at its start, so an NSTEMI. Okay, so typical clinical presentations of ACS, so acute coronary syndrome. So this includes all your angina, unstable angina, and your NSTEMI and STEMI. So it's chest pain with or without pain radiating to the shoulders, to the jaw, the neck, abdomen, and arms. And you should also be careful about abnormal symptoms. So things like nausea and vomiting, and epigastric pain, so pain kind of in your tummy. These kind of symptoms are usually typical in people with diabetes. Shortness of breath is a classic presentation, lightheadedness, feeling sweaty and clammy as well. And the main things for diagnosis is an ECG and your troponin. This helps classify which type of ACS it is. So with your clinical presentation, you do your ECG. If there is an ST elevation, you go down the STEMI route. If the ECG shows an ST depression or T-wave inversion, that's your NSTEMI. You want to kind of clarify if it is an NSTEMI or unstable angina. So you check the troponin. So if the troponin is raised as well, then it's an NSTEMI. If it's not, then it's likely unstable angina. Either way, you'd keep all these patients in hospital and you'd monitor your unstable angina and NSTEMI. And the STEMI, usually you ship them off to get a PCI. With the troponin as well, you need to make sure you always get two, which are about 4 hours apart, because it takes a few hours for it to actually start rising properly. Okay, we've got another ECG here. So we've got it's a 12-lead ECG for a patient on a surgical ward who complains of chest pain and episodes of vomiting and seems a bit feverish. So what's the likely diagnosis?
people are being quite quick on this one, and got lots of C's coming in.
Okay, so C is the correct answer. So this is your classic STEMI that you'd get. So you can see your kind of elevated ST segment right there. It's a straight line going up from the QRS complex, and you got the T wave kind of following along up there. This is your tombstone, and this is what you want to see. And this is the kind of ECG you'd get in your exams, because they're not going to make it that tricky for you. So they'll make sure it's very obvious. And you're right, it's anterior, because it's in kind of V1 to 4. You could argue that it's anterior laterals because it's V5 and a bit of V6 included as well. But anterior STEMI is the correct answer here. So just quickly going, so this is just kind of recapping what I talked about before. So these are the different ECG readings that you'll get. And then it's just a nice little diagram kind of comparing the troponin readings as well. So I thought it would be quite good for your revision, so I left it in there. So in terms of management, you've got your immediate management, so MONA, so morphine, oxygen if their SATs are low, nitrate, so you give them glycerol trinitrate, aspirin 300 milligrams, and then you got your clopidogrel or ticagrelor. I think in George's it's ticagrelor, right?
Yeah, it is.
Yeah. So George's it's that, so just remember that one for your exams, but it just varies from trust to trust. So in Ealing, we use clopidogrel instead. And then you decide if you want to take them for PCI or fibrinolysis. So indication for PCI is it's within 90 minutes of arrival for a STEMI, and the symptom onset was within 12 hours. You need to anticoagulate them as soon as possible, so you give them low molecular weight heparin or fondaparinux. Then for NSTEMIs, you can fibrinolyze them, and you can consider doing a PCI on them depending on the risk of complications. So if they're at very high risk within 2 hours of developing maybe a STEMI or further complications, you'd want to think about doing a PCI within 24 hours. If it's intermediate, then you monitor them in hospital and then think about doing it within 72 hours instead. And if they're low risk, you just monitor them. You can send them home, just keep monitoring them. With a CABG, so a coronary artery bypass, you usually keep these for people with multiple narrowed coronary arteries. But even if they've got multiple arteries which are affected, we tend to go for a PCI, because it's just less invasive than actually opening up their chest and doing a bypass. Okay. And then in terms of post-MI management, you'd want to put them on an ACE inhibitor or an ARB. So if they're not tolerating the ACE inhibitor because they developed a cough, then you put them on ARBs. You'd put them on a beta blocker as well. Ensure they're on a statin for the cholesterol, and you also put them on a dual antiplatelet. So you put them on aspirin with a PPI, and in the case of George's, it's ticagrelor. And for people with angina that you're just sending home, you might want to consider putting them on a beta blocker or a calcium channel blocker, and also give them some nitrates. And then complications of MI, so death is the ultimate one. Just in terms of timeline, within a few days you can get arrhythmias, you can end up with a free wall rupture because you've got all this kind of ischemic tissue, some scar tissue starting to form as well, and it's the tissue itself is quite variable, and cardiac tamponade as well. And you can also get this other thing called Dressler's syndrome, where it just you get inflammation of the lining of the heart as well. Other thing you can develop is heart failure. It can be acute, so straight after your MI, or it could be a long-term thing where you end up with chronic heart failure, and it tends to be your left heart, side of the heart, and you can end up with that can progress onto congestive heart failure as well. You can get valvular disease, and after weeks to months, sometimes you can get an aneurysm, and then Dressler syndrome can come up later on as well, where you get a bit of inflammation around the heart, because this is where you're kind of still kind of healing, and you've got all this scar tissue there. Okay, so just put some pictures there, and then just remember that MI can occur at any time. So, any questions at all? I know that was quite quick. I'm quite conscious of time as well, and I know people probably want to get dinner and go to bed. I'm going to take that as there's no questions, so I'm going to carry on.
Questions have come through yet?
Okay.
I'll let you know. Maybe start the next one. I'll let you know if any come through.
Okay, cool.
Also,
So,
just to say, I've posted, if people are heading off early, I've posted a link to the feedback in the chat. So if you do need to head off, we'd massively appreciate you filling it in before you go.
yeah, and you'll get access to the slides once you've submitted the form itself. So there'll be a link that comes up once you've submitted. Cool. So this is the last case for this module. So we're going through prematurity and respiratory distress syndrome. So first SVA, what is the Apgar score of a baby delivered at 36 weeks via emergency C-section? They have blue peripheries, a heart rate of 130, irregular breathing, a weak cry when rubbed with a towel, and flexing all limbs.
People were quite quick on this one. I'm just going to wait for a few more. We just had 3 answers.
People are on it with their revision, that's why.
Yeah. So far everyone is saying A.
Okay. So the answer is actually C. So I'll go through why. So I've written out what the symptoms are. So a blue, floppy, kind of inactive baby with almost no pulse, no breathing, that's obviously 0. This kind of, and just remembering what your 2 points on. So it's an active, crying baby, that's obviously pink with a normal heart rate, and it's kind of responding to your stimuli. So like when you're rubbing it with a towel and things like that, that will give you your 2 points max. And then
it said if it's only got blue peripheries, is that not 1 point?
So activity wise, it's flexing all its limbs. So that's 1 point. Next one, the pulse gives you 2 points. Then it's minimal, so it's a weak cry. So that's your 1 point there. You can argue 2 points there. 1 point for blue extremities, and then a 1 point for the respiration. So it does come up to a 6, 7 there. So if you go back to the options, so it would be kind of B or C. So 7 is because you're rubbing it with a towel, then you would say that's 2 points there. Okay, so next SBA, which structure is the remnant of the umbilical vein?
Just going to wait for a few more. So I've got mainly E's.
Okay.
And someone's been like, not A, B, or C.
That's exactly what I would have done in my head. Okay, so the answer is E. Well done, guys. So just to kind of go through a little bit of basic anatomy here. So your ductus arteriosus, So this is this little joint between your pulmonary arteries kind of going through there and the aorta. That little bridge there is your ductus arteriosus, and that forms your ligamentum arteriosum. Then your foramen ovale is that little kind of gap that you have, and that turns into your fossa ovale. So that's the little kind of oval window that you have. Then your ductus venosus is this kind of joint from the umbilical vein to the vena cava. That turns into the ligamentum venosum, sorry. And then your umbilical vein turns into the ligamentum teres. And then umbilical arteries is your medial umbilical ligaments. So these are kind of things that you just end up rote planning, and these are very niche random questions that come up. So if you remember it, you just get a mark for it. Okay, so just to kind of go through the switch from fetal to adult circulation. So during the first kind of 15 hours after birth, you have a fall in prostaglandins, which kind of is stimulated by your breathing in oxygen, and this leads to the closure of the ductus arteriosus. If it fails to close, then it's known as a patent ductus arteriosus, and this can lead to this sort of left to right shunt. So you can see all your blood kind of going up, and then because of that little bridge still being open, you'll just kind of get mixing of the blood, which is why it's like a left to right. And then these can be closed with NSAIDs. So this is why you try and avoid taking things like ibuprofen during your third trimester when you're pregnant. And if you need, for various reasons, to keep this ductus arteriosus open, you can just give them prostaglandins so it remains open as well. Then the next thing that closes within like about 3 to 7 days is the ductus venosus. And you can get portal hypertension due to liver cirrhosis, and that can cause it to reopen. And this is what leads to kind of this caput medusa kind of picture in babies. And then the foramen ovale, it's just closing the septum between the right and left atria, and that stops the blood kind of flowing between the atrium and ensures that it's going to the lungs instead of into the left side of the heart and to the body, so it's not mixing oxygenated and deoxygenated blood. The next one. So which cell type produces surfactant?
Cool, so we're getting lots of B's coming in.
Cool, so B is the correct answer. So type 2 pneumocytes. So type 1 pneumocytes, these are very thin cells which allow the gas exchange to occur, whereas your type 2 pneumocytes produce this surfactant which keeps the low surface tension within the airways on inspiration and stops the alveolar spaces from collapsing. Goblet cells secrete your mucus, and then you've got your ciliated epithelium which moves this mucus and traps particles out of the airways. And your chief cells are found in the stomach, and you'll be covering that in the next module, so don't worry too much about it, but sometimes they might just throw random cell types in there. The other key fact that you need to know is when surfactants are made. So surfactants gets produced around 24 to 28 weeks, and a sufficient amount is usually produced after 36 weeks, which is why you don't want to give birth before then. And like I said before, the main reason for surfactants is to stop the airways from collapsing when you're breathing out. And just have this kind of balloon here. So the first bit of air that you try to pump in is usually the hardest, but once it's opened, then it's easier to get air in and out of it. And that's exactly what the surfactant is doing. It's just keeping that first bit of air still in there. Okay, so respiratory distress syndrome. So this usually occurs if the baby is under 36 weeks when not enough surfactant's been produced. This means they'll have an increase in their inspiratory effort, so difficulty breathing, usually end up a bit tachypneic, so an increased respiration rate, tachycardic, so heart rate's usually raised, and then other kind of signs that you want to know are like nasal flaring, sternal recession, and the use of accessory muscles. So usually like the shoulders and things like that, you'd kind of want to look for. And then you'd want to do a chest x-ray as well, and you'll get this kind of classic sort of ground glass appearance on the chest x-ray. So you can see this kind of very like bitty, kind of like little bits of ground glass just kind of speckled around. Okay. So next SBA. So during which stage of lung development do type 2 pneumocytes develop? So this is a bit of a mean one and quite a niche one.
Yeah, people are slower on this one. I don't think they like it.
Yeah, it was quite a mean one, but I kind of saw it and I was like, oh.
Yeah, we're getting some answers in now.
Yeah. I just saw this in my notes and I was like, oh, maybe I should just put it in. Just, you never know, it might come up and you'll just get like a free mark for it if you get it right.
So it is very mixed.
Okay.
So some D's, some E's, and some C's.
Okay, so the answer is C. And this is one of the other things that you just need to rope learn a little bit. It's not something that you need to know in detail though. So typically you just need to know the kind of time frame they're developing. So when the lungs are developing, the first thing that develops is this kind of the branching of your bronchioles. So you'll get a bit of the foregut kind of coming through, that will kind of bud off and form your kind of trachea, your bronchus, and then those will form your bronchial branches, and that whole kind of your bronchial trees. And then eventually you'll start forming the kind of terminal acini, which eventually turn into your alveoli. And it's quite useful to just know when these things happen. So during the first 16 weeks is when you get this kind of bronchial tree kind of forming with the terminal bronchi and the bronchioles. Around up to 19 weeks, this is kind of fully developed, and you're starting to get your alveoli forming. And then around 22 weeks weeks time, you start getting your type 1 and type 2 pneumocytes. So that's your canacular stage, which was what was in the SBA. So it's just kind of remember around 22 weeks is when your type 2 pneumocytes and type 1 pneumocytes are forming, because this is when your alveoli are like starting to kind of specialize a bit more. And then around up to 36 weeks, it carries on developing. You start getting the shape of your alveoli, and then after birth is when you get all these kind of septums forming, and you start getting kind of the great structure of the alveoli. And then it starts getting that increased surface area. Okay. And then this I thought was just quite a nice diagram, just to kind of indicate how surfactant kind of plays a role. So with the lung development, without the surfactant, most of the air is going to go where there's more space, because typically you'd want to go where there's more space so you can kind of spread out a bit more. and it just means it's less tension. So with surfactant, it evens out the surface tension regardless of the amount of space, which means air can distribute evenly throughout this, the space in the lungs itself, instead of just going to where the largest spaces are. Okay, so we're getting towards the end now. So just kind of going through some of the changes that happen during birth. So when you're in utero, your lungs are filled with liquid. So you've got these chloride channels, which are pumping chloride ions into the alveolar space. With this, water follows because ions follow water, and sodium is the positive ion, which wants to kind of cancel out the charge, so it follows through as well and diffuses into the alveolar space. During delivery, with the release of adrenaline, with the oxygen that they're breathing in, the ion channels switch, the chloride ions are pulled out of the alveolar space, the water and the sodium channels start going through as well. And this is all absorbed back, and it allows for the air to kind of replace the space instead of the liquid. And then you get your surfactant kind of forming, and it starts thickening up in the wall and allows it to form that surface tension. A key thing to kind of remember here is that babies which are born in C-sections might have transient tachypnea of the newborn, as they've not really gone through this process of labour, which is quite stressful for not just the mother but also the baby, which is what releases adrenaline. Okay, and just quickly going through the management for RDS. So antenatal glucocorticoids can be given if they're expected to be preterm. And this kind of reduces the incidence of RDS and any other complications that the baby can have. Aim for SATs of 91 to 95 if you're going to give them oxygen, because you don't want them to end up with necrotizing enterocolitis. And it also reduces the risk of retinopathy. So having too much oxygen is actually quite bad for the baby. And you can also put surfactants directly into their airways as well, using a tracheal tube or a catheter to help them kind of get that surface tension and help them with their breathing. And sometimes none of this is really helpful, so you might actually need to put them on a CPAP or intubate them or ventilate them. Okay, so that was a quick whistle-stop tour of RDS. Any questions at all? I'm going to take that as a no.
Just some thank yous. Oh, that dancing baby is really addictive to look at.
I know, right?
See,
I like that one, baby. Everyone up. It really wakes me up.
People saying thank you.
SBAs for the foundation module if anyone does want to stick around. And if you've got any questions about exams as well, we're around. So, we've got an ABG here, so what does it indicate? So take your time and just kind of go through it, and I'll explain it in a bit. So I think I'm just going to time it for 30 seconds, 40 seconds maybe?
Yeah.
Yeah.
So we've got some people saying B.
Nope, so I'll give it a bit.
Well, 4 Bs so far. Another B.
Okay, so 5 more seconds, and then go through the answer. Okay, so the answer is B. So well done, guys. So just to kind of go through the different types. So we've got a high pH, so that's alkalosis. The way you know if it's respiratory or if it's metabolic is looking at the CO2 and the bicarb. So I put this here because it's quite useful to help just remember patterns. So the way I remember it is, if it's acidosis, you look at the pH and look at what is likely to cause the acidosis. So CO2 is acidotic. So if that's increased and the pH is decreased, then it's very likely it's something to do with the respiratory system. And then with alkalosis, there's low CO2. So that means it's more alkalotic because you've got less of it. And then with metabolic, you've got low pH, there's low bicarb, and that means when those two match, then you know it's a metabolic acidosis. And then if the pH is up and the bicarb is up, then it's metabolic alkalosis. Now, in terms of compensation, it's the other component which helps compensate for it. So in respiratory acidosis, you've got an acidotic CO2 concentration, which is high now. So in order to compensate for that, you want to start trying to convert that into your bicarb. So your bicarb increases, which is a bit more alkalotic. So if it's partial compensation, you'll have these changes, but the pH hasn't changed. If it's not compensated at all, then there would be no change in the bicarb levels. And if it's fully compensated, your bicarb and your CO2 will be doing, but your pH will be resolved, which is why we call it full compensation. So in this case here, it's a respiratory alkalosis. So you've got high pH, you've got a low CO2, and the bicarbs come down as well. So it's very likely that the bicarb's trying to convert into CO2 to increase the acidity. So that's your partial compensation. And if it was fully compensated, then the pH would be back in normal range. Okay, and the same sort of principle goes for your metabolic acidosis and your alkalosis as well. And I just wanted to touch, because this is your carbon monoxide case. Your carboxyhemoglobin should usually be between 94 to 100%. Your oxyhemoglobin, sorry, and your carboxyhemoglobin should be under 2%. And it can go up to 2 to 9% in smokers, but if it's over 10%, then you would want to suspect carbon monoxide poisoning. SSBA. Which of these does not cause oxygen hemoglobin dissociation curve to shift to the left? So I'll give another 30 seconds. Okay, what do we have for answers?
We've got all E's.
All E's. So answer C. So the question's asking does not cause it to shift to the left. So it means what's causing the right shift. So I did this on purpose just to make sure people are reading the questions carefully, because I'm one of those people who doesn't read the question carefully and gets it wrong. So things that cause the left shift are a decrease in temperature, a decrease in 2,3-GP, decrease in CO2, and an increased presence of your fetal hemoglobin. Your right shift is due to an increase in the pH. Then you've got your increase in CO2, increase in your 2,3-DGP, and increase in temperature as well. So it was a bit of a mean trick question there. Next one. How is majority of CO2 transported in the blood? So another 30 seconds. Okay, 5 seconds left.
I can't access the chat, but I say B.
Cool. So everyone so far is saying B.
Okay, cool. So B is the correct answer. So carbon dioxide, majority of it does go around as bicarb. Remaining majority, so about 20-something% is bound to hemoglobin, and a small percentage of it goes into the plasma and dissolves in there. Oxygen, most of it's bound to hemoglobin, so 98% of it, and the remaining is dissolved in your plasma. Okay, so this is a bit of a wordy one. So you got a 75-year-old lady with a background of dementia who's seen in the nursing home by the GP. She has 8 episodes of diarrhea in 24 hours and reduced oral intake throughout the day. On examination, she's got dry mucous membranes, reduced skin turgor, her blood pressure is 88/50, heart rate's 112, rest rate's 22. Blood show increased urea and sodium levels. What's the most appropriate next step? So, another 30 seconds. Okay, I went for 40 seconds. It's got a lot of reading there, but yeah.
So got a mix of C, A, and D. And there's also a question on the previous question once you've gone through this one.
Okay, cool. I'll go through this really quickly and then we'll go back to whatever the question was. So the answer is E. So with this patient, you're kind of considering if they've got some sort of gastritis or any sort of organism that's causing an infection, which could be contagious. So you don't want to spread it, so you put them in isolation, and you do need to give them fluid replacement because they're an elderly patient who's got dementia. It's very unlikely you're going to be able to get them to drink. So you'd want to just give them IV fluids instead. So the key bit here is keeping them in isolation in hospital. So usually a side room, and then give them some fluids as well. You don't really want to just send them home. And reviewing them in the week's not going to be really helpful here. It'll probably just deteriorate a bit more. And encouraging oral intake in a dementia patient isn't always the best thing. You can try, but you'd have to physically sit there and get them to drink. And giving them, again, oral rehydration therapy in hospital is not going to make a difference either. And the key thing here is isolation and giving them fluid replacement. So what was the question in the chat?
So the question was, sorry, just on the previous oxygen dissociation curve question, wouldn't a high pH cause a left shift?
Yes, so you're right. So it's the high amount of your hydrogen ions, not the high pH, sorry. Yeah, so it would be decreased pH would be the option. I'll make sure I change them on the slides and the handout. Any other questions?
Nope.
I think we've only got 3 more SBAs left. So this one is, I think, the last one from me. So chlorotoxin binds to the cell receptors in the colon, leading to secretion of chloride ions into the intestinal lumen. Sodium ions and water from the extracellular fluid follow consequently. What is the tonicity of the extracellular fluid in relation to the intracellular fluid, and which direction will the water move? So this is a lot of thinking here.
So we've got a couple of answers in. People so far are saying C.
Okay. So we've got 5 seconds left. Okay. So the answer is actually A. So things are moving out. So the water's moving out from with this sodium ions as well and the chloride ions. So the tonicity is actually going to, because water is actually diluting everything, it's the water that's kind of coming out more. So it's going to increase that concentration in the extracellular fluid, which is going to try and shift and dilute itself a bit more. So it's kind of like opening a tap and then opening another tap. So it's going to move from the ICF into the ECF. And the reason why it's doing that is because the ECF is a bit more hypertonic than the ICF at this point. That makes sense. I'm going to take that as a yes.
Yeah, no one's. Oh, what about the sodium? Someone said.
Okay, so the way I remember it is that the water moves out in more mass. So the sodium is moving out, but the water's kind of following sodium and the chloride ions. The chloride ions are actively being pumped up, so the water is going a lot more quickly than the sodium ions. That makes sense. So the key bit here is in relation to the intracellular fluid. So it will still be more hypertonic because it's quite dehydrated at this point.
They've said great, thanks.
Do you want to share? Do you want to just do it from mine, or do you want to share your own slides?
Yeah, I can just do it from mine. Are quite quick ones anyway.
Okay.
So first question: which of the following is not known to cause a macrocytic anemia? So B12 deficiency, folate deficiency, reticulocytosis, anemia of chronic disease, or methotrexate.
Are you looking at chat? I'm assuming.
Yeah, I can.
Yeah. Okay. About 5 seconds left. Should we go through the answers?
Yeah, then you had one answer. Oh no, 2 answers. Okay, so 2 people have put C, 1 person's put D. So the answer is D. So all the others cause a macrocytic anemia. Anemia of chronic disease is In the early stages, it's normocytic, and then in late stages can become microcytic. Reticulocytosis, it means having lots of immature red blood cells. And the immature red blood cells are actually really big. And so it's a macrocytic anemia. In terms of like remembering what causes macrocytic anemias, there's a mnemonic that's FAT RBCs. That stands for folate. I've like lost what it stands for now. What else does it stand for? Having a brain, but I was going to present. Anyway, folate deficiency, alcohol, thyroid problems, reticulocytosis, B12 deficiency, and cytotoxic drugs are the things that cause macrocytic anemias.
Thank you. You ready for the next one?
Yeah. Can we skip this one? This question's not very fun. In sickle cell anemia, a point mutation on chromosome 11 leads to an amino acid swap. Glutamate is swapped for which other amino acid? This is just one you've got to remember, but people are answering quite quickly, so I think you all know. So I might just go through it. Okay, maybe I'll give it 10 more seconds. I feel like this is one you either know or you don't. So yeah, everyone so far has got it right. The answer is E, which is valine.
Yep.
It's just one you have to memorize. There's not really any fun way of remembering it.
I think that was it. Yeah.
Yeah.
So
Thank you so much for staying so late, everyone. We hope it was helpful.
we've got the QR code up here as well. If you guys could fill in the feedback forms, I'll make sure those slides are changed. The ones that had a bit of an error in there.